Can you hear me all right?
Yeah, yeah, can hear you. I can see your screen as well.
Thanks. Cool. So yeah, thank you for having me back again and for the introduction. Yeah, so a year ago I came and spoke to your team about the plans for the study because we'd only really just got it off the ground at that point, but a lot has happened in the last year. So I'm going to try and do a summary of where we're at with everything, including the results of the first study really, which we finished now, essentially, and moving on to also now getting ready to start the final phase in the new year. So yeah, a bit more of a kind of result summary today and where we're at, but also a little bit of telling you about the kind of methods for the next phase as well. So yeah, the title of the study is the development of a physical activity maintenance intervention for people with persistent MSK pain, and we're particularly interested in helping people to maintain physical activity long term after they've done pain management programs and focusing on a musculoskeletal population for that. So yeah, really trying to focus on that maintenance aspect. We know that in pain management programs, we often get like a boost from people during and after the program with their activity, but it's just really trying to focus on how we help them to stay there long term with those changes. So yeah, I'm going to give you a kind of a brief overview again of what we're doing in the study, talk about the findings for phase 1, and then a phase 2 update, and also a little very brief kind of what's coming update as well. And just say we did publish the protocol for the whole study in BMJ Open earlier this year, so you can view that, and that's a more detailed breakdown of the methods for the whole project together. So yeah, as a quick summary, we're recruiting from 4 different pain management programs in the NHS. Obviously, at the RNOH where I'm from is one, the Walton Centre is another, and then also from Input at St Thomas's and the Oxford program as well. So for phase 1 or work package 1, which is what I'm going to tell you most about today, this is kind of study made up in three different phase work packages. Was a number of, so work package 1 was a load of qualitative interviews, really trying to understand the barriers and facilitators to physical activity maintenance after pain management programs. And we also asked people about the what characteristics could be in the intervention, what could it look like, what could it include. In work package 2, which is ongoing, we're doing a prospective longitudinal study where we're looking at some of those barriers and facilitators and trying to look at their association with physical activity maintenance, and also collecting some more intervention characteristic suggestions from participants as well. And then in work package 3, we'll be bringing that all together to co-design the intervention in a number of stakeholder workshops. And that will include patients, their partners, and health professionals as well. We're using the behaviour change wheel as an intervention development framework, which I'll talk to you more about on the next slide. And yeah, I just want to always make a nod to my patient and public involvement group, who are a fantastic group of people that are really, really integral to all of this. So some of you may have seen the behaviour change wheel before, but some of you may not. So it's a really systematic, complex intervention development framework designed for behavioural interventions. It was designed by Susan Mickey and colleagues at UCL, and I'm very lucky where one of my supervisors is a member of Susan Mickey's team. It's essentially 8 different steps to work through the design interventions, all the way through from really trying to understand what the behaviour is, to a behavioural diagnosis, what they call it, but really it's understanding all the things that influence the behaviour, so essentially the barriers and facilitators, which then moves through to intervention types, policy types, if the intervention will be influencing policy, and then looking at behaviour change techniques and modes of delivery as well. So in phase 1 of Pamper, yeah, I said we really want to understand all the barriers and facilitators to particularly maintaining physical activity long term. And this relates to this middle section of the behaviour change wheel framework. We're really trying to make that behavioral diagnosis, understand the most important things for influencing physical activity maintenance. So our participants were patients that were between 6 and 18 months since finishing a pain management program. So we wanted them to have some experience of maintaining activity, but also not so far away that they weren't engaging with contact, or that they might have forgotten kind of what that initial phase was like for them. And we also included what we called them physical activity partners, and that was people that support them with physical activity or someone that they do it with. And then healthcare professionals working on pain management programs as well. So all participants were recruited by email from members of the site clinical team, and then they expressed interest and were screened and consented by me. We used a purposive sampling method because we really wanted to get a range of participant success at maintenance of activity self-identified by them. We wanted some people that felt they were doing really well and other people that were perhaps struggling a bit. And we also wanted a range of demographics and sites as well, and then different professions for health professionals. So we use semi-structured interviews, and most of these were individual interviews, but if a patient had their partner present, I interviewed them both together in a dyadic interview. And then we used a reflexive thematic analysis approach as the first step to analysis, then had a number of sub-themes from that we mapped onto the theoretical domains framework, which I'll introduce in a second. Now, we really wanted to understand how different sub-themes will interact with each other and link that to the TDF as well, the theoretical domains framework. That's helped us to understand what might be the most kind of influential barriers and facilitators as part of that. So we ended up with a lot of different ones in the analysis, as you'll see. The key step to that was trying to understand which ones to prioritize. So through coding the interviews, we're able to understand any interactions between different barriers facilitators and therefore sub-themes to try and understand what might be the most influential. And we also sort of developed and constructed some different patterns of physical activity in the data. Now, what we mean from that is the different trajectories that patients face when they finish a program up until when we interviewed them, and I'll show you some of those as well. So for those of you not familiar with the TDF, it's a behavioral framework where it consists of 14 domains that essentially summarize from lots and lots of different behavioral change theories. And this is a really nice way to categorize different barriers and facilitators that condenses a lot of complex data in a more simplified way, and it maps directly onto the behavior change wheel framework. So it's a nice way of just seamlessly moving our results towards intervention development. So some results. So for the interview characteristics, I did 32 of them, and 24 of these consisted of patients, of which 7 of them had their partners with them, and there were 8 health professional interviews as well. Most of these were via video call. I did a few in person and 4 on the phone as well. In terms of the patients, we had a median age of 54 years. The most were females. We tried really hard to get male participants and pretty happy to get 7 of them in the end. I think that just corresponds with the type of people that are attending pain management programs. We had a vast majority of them were white, and a good mix of education and employment statuses as well. So we managed to get an even split of those that described themselves as being quite consistent with activity. And the way that we phrased that when we asked them the question was, are they repeating a kind of higher amount of physical activity since they finished the program on sort of most weeks, or nearly every week or most weeks? And then the inconsistent or inactive group were people that were perhaps either doing a bit more activity, but a bit more kind of sporadically, or had fallen back and were doing less than before their program. So yeah, there's sort of an average of 11 and a half months from finishing a program, with a good range of that kind of 6 to 18-month period. Quite a long time of pain duration, most of them with multiple pain sites and multiple diagnoses. And as expected, quite a number of different comorbidities as well, with mental health, cardiovascular, and GI being the most common. Of our physical activity partners, so 7 of them, they were all spouses or partners of the participants. And most of them had health conditions themselves as well, and actually most of male in these situations. And for our health professionals, we had 4 physios, 2 OTs, and 2 psychologists, and all really quite senior at band 7 or above, and generally an experienced group of people as well, at about 13 and a half years on median from working on programs. So there's quite a lot of data. So this is quite a brief overview of the results we had. We are very close to submitting the paper for publication. So as soon as that is published, I'll also make sure that you will receive that as well. But from the barriers and facilitators data, we generated 5 themes, all with a number of sub-themes, which mapped onto 13 out of 14 of the different PDF domains. So in the first theme is about all those internal factors, internal drivers that influence physical activity maintenance, and that, you know, people's feelings around maintenance, what their beliefs about how valuable it is, their beliefs in their ability. So that's referring mostly to confidence, their goals. Now with goals, the goals were mostly around things they wanted to gain from it, rather than the amount of activity they wanted to do. So it's more sort of like bigger lifestyle reasons. We've had this sub-theme around remembering the past and accepting now. So that's about their relationship with memories of what their activity was like before they had pain, or before pain became a real burden on their lives. And then there's another something at the bottom about keeping track and checking in. So that's about kind of self-monitoring and reflecting on activity and how influential that is. So most of those sub-things were barriers and facilitators. Barriers or facilitators, depending on the person and how these were present amongst those people. And these relate to a whole host of different TDF domains as well, but lots around kind of emotion and beliefs about consequence capabilities as well. So the next theme was about how physical activity interacts with all the features of someone's life. So competing demands and life roles is a prominent one, and that was prominent for all the participants really. And those are things like work, caring for family, you know, caring for themselves, caring for family, work, other hobbies, and then habits, routines, and being able to remember activity, and planning, and how they're able to plan activity and how successful they can carry out those plans, and other health conditions. So it's all about the interaction of other health conditions with their pain and with physical activity. And then the last bit of this is about adapting, and often the people that were more successful with maintaining activity were those that were able to adapt their physical activity around these other features of their life to ensure they were still doing as much as they could despite those other things. And this very much relates to, again, a lot of different TBF domains. We've got environmental and social factors in there, as long as with these kind of skills and behavioral regulation aspects as well. And then we have a theme around symptoms and symptom management, and this is directly referring to their persistent pain symptoms and how they manage these. So the first sub-theme, influence of symptoms, is all about how much their symptoms of persistent pain influence their physical activity. So that could be around the pain itself. Fatigue was obviously a very prominent symptom within that as well. In symptom management, that talks about how if people are able to manage the symptoms of their condition, then they're more likely to be able to maintain their physical activity consistently. And that consists of all the different pain management strategies that patients were using at the time of interviews, of which pacing was the most prominent one that relates to them being able to be consistent with their physical activity. And similarly to the last theme, there's this concept of being able to adapt to their symptoms, and definitely those that are able to sort of be flexible with their activity in terms of what they did, how much they did, how intense that was, would be more successful at maintaining a level of activity as well. This next theme around all the social influences and their social network around maintenance of activity, and very simply, if they have encouragement and they're motivated and have positive emotional responses from other people, that's likely to be very beneficial, as is practical support. So things like advice, or things like just helping support them when they're actually doing an activity such as walking. Within those two sub-themes, there was a bit of a vulnerability described by some people who are heavily reliant on having someone to do it with or someone to support them. If they had someone like that where they perhaps needed to have somebody with them to do activity, if those people weren't with them, that often meant that they wouldn't do it. There's a bit of a vulnerability if they're overly reliant on those people for those things. And then there's a sub-theme around that kind of negative influence of other people as well. So that was mostly related to family and friends being unsupportive or not understanding of their needs as well. And then the final theme is all the environmental influences on activity as well. And I think most of these sit within the kind of public health space as much as the healthcare realm, really. But location of physical activity is about whether people have places around them where they can do, whether they're places to be outside, or whether they have accessible and suitable indoor spaces like gyms and swimming pools and things like that, or whether their home is appropriate for people that wanted to do more home-based activity. If they've got a lot of clutter or other people at home, that's not always conducive to doing it, whether they've got more space and the right equipment. There was quite a lot of talk about the financial influences on activity. This was mostly barriers for people. The cost of attending a group or getting a gym membership, or even the transport to get to places, was a big issue for lots of people from that perspective as well. There was a couple of people who said that financial, if they commit to paying for something, that actually acts as a facilitator for them. But the most overriding prominent aspect there was about barriers for people. The organised opportunities refers to things like the availability of a suitable groups and classes for people with pain, of which, again, a few people were very positive about this, but the vast majority of people highlighted that there weren't often available and suitable and accessible opportunities for people with persistent pain around. And then the weather is the weather, of course, which is mostly a problem if the weather is bad for people. So that's a real whistle-stop tour of the barriers. And as I said, I don't have time to go into too much detail now, but hopefully when the paper comes out, there will be a lot more detail about those there. But then we started to map out all the different interactions between different sub-themes. So each of the kind of boxes here refers to a different sub-theme, and all the arrows are how they might influence another one. Now that's quite busy and a lot going on, and really difficult to prioritize that. So we need to have a system where we can identify which ones were actually significant, because some of these could just be one person inferring that. And when we did that, we ended up with 5. So we developed a criteria for really doing this, was about thinking along the lines of what a thematic analysis is like. So we need to have some patterns of different interactions between the sub-themes as well. And also within the data referring to these, we needed people to sort of be inferring some significance with them as well. So this is quite a novel method for doing this, and not many people have been using data in this way when looking at barriers and facilitators. We end up with saying, okay, the encouragement, motivation, and positive emotional responses from others can positively influence people's beliefs, so their confidence around maintenance. If they're receiving lots of encouragement and motivation and say positive feedback from people, that can make them feel more confident with their activity. Also, there's the practical support, so advice, receiving like physical support to do activity can positively influence how they feel about it. So a simple example of that is if they're having someone that supports them or goes walking with them, they might feel safer or less likely to fall. The next one about competing demands, positively and negatively influencing habits and routines. A simple example of that is if people have lots of other competing demands, it can be difficult to form habits around that as well. But likewise, if they're able to amalgamate physical activity within their daily routine, that is a positive influence there as well. And then the next one is believing in the value of activity. So that's mostly around whether people believe physical activity to be something which is useful for them or beneficial for them, can positively influence their goals. If they think it's going to be beneficial, they're more likely to set goals around it. And that can also influence how they feel about it. If they're feeling beneficial for them, they're more likely to feel good about doing it as well. And we hope this will be really helpful for us in trying to prioritize some of the things that we target in the intervention moving forward. So with physical activity patterns, this was the 4 that we constructed from the data, the ways that patients were describing how they were getting on with physical activity since the pain management program. And there tends to be 4 quite distinct patterns here. So in the consistently active pattern, this is people that were doing a kind of consistent amount of physical activity every week or nearly every week that they described as being more than before the pain management program. And there was some people in this group that had been consistent since they finished the program with sort of minimal lapses. And there was a few people that were initially inconsistent, but were now consistent at the time of interview. In the next one, so inconsistently active, but initially consistent, describes people that were more inconsistent with their amount of activity when we interviewed them, but described being a lot more consistent when they initially finished the program. So there's some people there that were initially doing well and then have sort of dropped off and are now not so consistent. The next one is a group of people that were inconsistent just since they finished the program, have always had difficulty with consistency. And then there was a much smaller group who said their physical activity had either not changed at all since they did the program or had in fact reduced. So we think this is helpful for the intervention because it means we can tailor it. And we know that we obviously have seen some examples here of how they can change. So people that were initially inconsistent are now consistent, or initially doing well but had become more inconsistent. And we can see how people can potentially move from different patterns as well. And this will hopefully help us tailor some of the intervention components as well. We also looked at which sub-themes might be different between those in different patterns as well. And just some key differences between those patterns was that there's the people who are more consistent tend to have more positive and less negative feelings towards physical activity. They have a better relationship with their past memories of physical activities, what it was like before they had pain or pain became a burden. They're actually more likely to monitor and keep track of it. There were very few people in the other patterns that kept track of their activity. The people in the consistent pattern are a lot more likely to be successful with managing their symptoms, more likely to adapt their activity to having fluctuations in symptoms. They're more likely to have better support from other people and have access to suitable places for activity. And those who were more inconsistent had sort of mixed feelings towards their activity, mixed beliefs. So they might have some positive perceptions of doing activity, but also have some negative beliefs still there as well. More likely to be less confident, more affected by other health issues and their persistent pain symptoms, and more issues with where they have to do their physical activity, so less access to those places as well. So that's just a few key differences between the patterns. And yeah, we think if we recognize people are in different patterns or different places, we can tailor intervention components to perhaps target some of the things which are more prominent for them at different times. So in terms of strength of that study, we had different stakeholder groups, multiple different sites representing all different geographical variation from across the UK. We did a multi-layered analysis and involved some established behaviour change intervention development frameworks. We successfully satisfied our sampling criteria, and yeah, PPR group have been really important throughout. We did have mostly people from a white ethnicity. We did wonder whether all our physical activity partners were spouses or romantic partners of the patients, and we do wonder if we had other partners with different relationships, whether their views may be different. For example, if we had a son or a daughter or a kind of carer, that might be different. And some of the health professionals I spoke to did say actually it's a little bit difficult at times if they're not seeing people much after programs to really understand what their barriers and facilitators are. So they felt they may be speculating at times a little bit. So my take homes from this is that the barriers and facilitators are very different and they present very differently for each individual. And summarizing it is actually very challenging to do. And they are dynamic and they can change over time. I think this is an indication for needing long-term support is how much these can fluctuate. We recognize that from a theoretical domain framework point of view, skills and behavioral regulation domains were very common. And we think this is particularly important for maintenance as is different to what's in other studies. But this might relate to the fact that people have been taught a lot of different skills and ways of trying to maintain behavior during pain management programs, but also highlights the importance of being able to continue to use those strategies and be adaptable long term. We also knew that some of these facilitators are not able to be utilized by all participants. I interviewed a number of people who were autistic or had ADHD and said actually things like forming habits sounds like a really nice idea, but it's actually very difficult for them. And that's just an example of where some of those facilitators, if we put them in an intervention, would not actually be suitable for everybody who takes part. And I think that summarizes why one-size-fits-all interventions in the past haven't seemed to work. As I said, we know that physical activity patterns can change over time, and actually there are distinct differences between the types of barriers and facilitators people face at different times. And I said, I think there's lots we can do with a healthcare intervention here, but we will still be limited by some of the things which sit more in a public health space around accessibility and finances, and we have to really consider how we help people that have those barriers, even if we can't change those structures ourselves. I think what I'll probably do is, because of time, give a quick read. The other two bits are much shorter, so I'll quickly go through them and then open up for any discussion and questions after that. So moving on to phase 2. So what we wanted to do in phase 2, I said, was a prospective longitudinal study, looking at some of these barriers and facilitators more quantitatively and explore their association with maintaining physical activity. So we did a preliminary analysis of the first 10 interviews in phase 1 and designed a questionnaire that simply asked people about some of those barriers and facilitators. Takes about 15 minutes, and we're doing baseline collection for this and then 6 months later as well to follow them up. And we're recruiting people for this immediately as they're finishing a pain management program. We're then monitoring their physical activity for 4 weeks at baseline and 4 weeks at 6 months. After the first 4 weeks of measurement, we give them a really good breakdown of their activity levels, so different intensities of activity, sedentary time, and sleep time as well, and set a target with them how much activity they want to maintain each week for the next 6 months. And then when we redo the measurement at 6 months, we're looking to see how many weeks they hit that target, and that's how we're assessing the maintenance. And we're using it that way to make sure it's very personalized to people. As we know, if we set goals and targets for them, that's not going to work with so much variation for people. And we've decided that for the study, they need to have achieved that goal for at least 3 out of the 4 weeks when we follow them up to see if they've maintained their activity. So at the end of pain management programs, they're being given a whole host of resources about information about the study. And then at RNOH, we're consenting them on the site, or if they're from other sites, the patients are filling in a consent to contact form to express their interest, and then I screen them and consent them remotely. To same 4 sites throughout the whole project. And our recruitment so far, we've got 86 participants in the study, and we're going to keep going until we get 100 people as well. But there's been some really successful months and some less successful months as expected, but we just looking for that final push to get those final people in, and then we'll stop recruitment at 100. These are the accelerometers that we're using to monitor physical activity. So it's called the Gene Active Accelerometer, and they're really small and really light, and they just wear them on their wrist like a watch. They're fully waterproof, so we're asking people to wear them 24/7 for 4 weeks, and only take them off if there seems to be a problem, or maybe they're having a wash, or they need to kind of check the skin underneath them. And they don't give the participants any feedback. There's no screen. They don't get any feedback from them. Just have to wear them. And the idea of that was that they would be less of an intervention without feedback. Although I think every patient I spoke to told me they weren't motivated by wearing one, which I'm not surprised by. And this is what we give them in terms of an activity breakdown. So we give them an averages across all the 4 weeks and all the 28 days of measurement in terms of all their light, moderate, and vigorous intensity together, and then the moderate to vigorous analyzed separately, and a sedentary time and step count breakdown as well. And then a summary of each of the 4 weeks, and that just enables us to see patterns and consistency levels across those 4 weeks as well. And when we're setting the targets with people, I tend to say if all 4 weeks are similar, maybe they want to set a target around what the average is, or if there are some differences like this one here, maybe to set it around what a normal week felt like for them. And the target is around their sort of total movement, so all the light, moderate, and vigorous activity combined. And apart from the software gives us a graph for every day. So we're able to give people these as well, and then they can see what their activity is like as these graphs go up and down, depending on whether they're asleep, and it moves up sedentary and light, moderate, and vigorous as well. I get loads of questions about these from people, and sometimes they're very difficult to measure because people are like, well, I was going for a walk, what type of activity would that be like? And I'm like, well, it doesn't quite tell us that, but it does tell us a lot about, boom and bust patterns potentially for some people. So I do get an opportunity to explore some of those things when I discuss it with them. So that's where we're at with phase 2. So as I said, we're in the follow-up phase now. We've got about sort of 15, 20 people doing their follow-up measurement now. And we're nearly at our target recruitment rate of 100 as well. So hoping to wrap that up by the end of October in terms of baseline assessments anyway. So for the next few months will be, as I said, we also asked lots of people in work package 1 or phase 1 about intervention characteristics. We put all that data aside initially, and we're now looking into that a bit more, as that is going to feed into our co-design in work package 3. Hoping to submit the paper for the barriers and facilitators section of work package 1 for publication soon. As I finish recruitment phase 2, and then plan and recruit for the final work package. So what that looks like, and a bit of a plea from me, is that we're currently be developing the kind of theory and logic model around what that might look like from the other results from the other 2 phases. And then we'll be running a series of co-design workshops to develop a prototype of the intervention and then get some feedback on that and refine that. So we're currently trying to work with all the sites to identify what is feasible for them and what we're likely going to be able to do. As I said, these workshops would include patients, health, PMP staff, and patients' partners as well, where they want them to take part. So probably going to be about sort of 3 to 4 2-hour workshops in the first section, and then 1, maximum 2 2-hour workshops in the refinement phase. They'll initially be separate patient and health professional workshops, and then we'll bring those 2 different groups of people together for the final workshops. And there might be some kind of short surveys or feedback activities in between. And we need about 2 to 3 maximum different staff from each site. So that your recruitment invites for this should be coming out towards the end of the year, as we're just trying to work with all the different sites to know what's feasible, because I know that everywhere's got staffing issues and very busy at the moment. So we're really trying to understand what sites are going to be able to release staff for, and a bit more information about that will be coming out to everybody in the next couple of months. But if you're interested in helping us design the intervention, or take part in either the initial workshops or just give us some feedback on the prototype, then it'd be great to chat to you more about it and have you on board. And I'm going to stop talking for a minute and see if we've got any questions or anybody wants to say.
That's lovely. Thanks, Greg. And I think Katie's actually mentioned to me, about the recruitment for the workshops.
Yes.
So I know it's on Katie's radar. So I don't know if perhaps if people are interested, it might be something that they approach Katie around. Anyway, we'll open it up to questions. So, John, you just about got your hand up first there.
Yeah. Hi, Greg. Thanks for that. I was wondering at the beginning of the talk whether this is just based on patient reports of physical activity, or whether there was like an actual objective measure alongside that as well. But I think you kind of spoke about that in the second half. Was that included in the first half, was like an objective measure as well as the report?
No, in the first package was just when I was screening people, I was having a conversation with them about how consistent they thought they'd been since the program, and it was all on how much they self-identified as that read for the first bit.
And
which I think is why when I did the analysis of the different patterns, it's a little bit different, the numbers in that, to what people identified as initially. Because I think it's, when I sort of delved into their actual experiences a bit, that did change.
That's what I was wondering when you were talking at the beginning, because obviously we come across patients who might talk about a particular level of activity, but whether that is reflected in real life. And I'm thinking about people who, will say things like, "Oh, there's no way I could manage to attend a program of that intensity," but yet they do manage it, and those kind of things. I also wondered, a follow-up from that is, has there been any comparison between the reported physical activity levels and the objective activity level?
So for the second study, there was a different participant group, so we're actually not collecting that self-report. For the second, we know from lots of other research that there are massive differences in what people self-report and what their objective says. So I think we're pretty confident we know what happens in that situation. So we didn't really feel a need to do that for this as well.
Thank you.
Thanks. Zoe?
Thanks, Greg. That was really good. Some of us are doing we've done a project and we are slowly writing it up at the moment, and that's the qualitative focus group study looking at whether exercise videos, online exercise videos, would help patients post PMP keep up exercise long term. So as an opening question in the focus groups, we asked them about what keeps them going with exercise and what gets in the way. So there was so much of what you said today, and in the first phase of your PhD, that the answers that you've got are very, very similar to what we've got. So that's quite reassuring, really, that we're getting the same answers from them. We had 13 people in 2 focus groups compared to your bigger number. One of the main things that stuck out for us was that still post PMP having fear of exercise and needing that professional support sometimes ongoing, because we just felt that some patients still don't have that autonomy, and continuing exercise under their own steam is still so difficult. So well, I don't think videos is the answer. Online exercise videos is the answer, but like you said, one size doesn't fit all, does it? So it can help some people, I would think, but certainly not the answer. So yeah. Thank you very much. And I'll probably do an REM at some point on our study. So hopefully Alison can invite you to that.
That'd be great. And it's really interesting to hear what you said about fear then, because that was a really interesting thing that I found as well, was people talking about how they often had it reduced, but it remains a bit, or it kind of, if their pain is higher, they're more fearful just at that point, and when it settles down, they feel better. And some people thought about how actually they were much more fearful. They were less fearful after program, but then it perhaps came back if for lots of reasons. So it's just a very dynamic thing, and certainly isn't something which stays the same when people do a program. I think your exercise videos, I think, is an answer. It's certainly something that came out of the interviews as well, and something that a lot of people thought would be really helpful for them. So I think it is definitely part of a package of support that people need. And yeah, I'd be very happy to come back and hear about the results of yours as well.
Yeah. Look forward to your paper when you publish it. Hopefully we'll get ours out at some point too.
Thanks.
Thanks,
Thanks,
Sally.
Greg.
Graham? Oh, Graham, you're on mute.
Thanks, Alison. Yeah, thanks for that, Greg. Mightily impressed with all your work there. It's incredibly impressive. It was one of the slides what I thought was really interesting. It was we talked about like physical activity pattern, and I think that you mentioned that I think it was at 10 would consistently continued with exercise post PMP, the PMP, but 14 didn't. And then I sort of, was there a link and a correlation between those environmental influences, like these health inequalities, and that group of 14 who basically tailed off with their exercises?
That's a really good point. I do have that kind of summarized in terms of the types of barriers and facilitators they reported. I think there is definitely a difference between those that were struggling would report more barriers with access, or certainly I have the memories of some participants that spoke about if they rely on going outside for a walk as their activity, that's better than those that kind of wanted to do it in a kind of gym environment or in a pool where they perhaps don't have the same, or access is more challenging for them. And there's definitely more financial issues amongst those groups as well. So yeah, definitely some of those factors are more prominent in people that are struggling. Yeah.
From the conversations you had with these group of people, did you pick anything up what they sort of identified, what from that group of individuals, what might promote them to keep on exercising after?
No, I think that's
the big question. But,
yeah,
obviously spoke to a lot of people.
Yeah, I think that will come out more when we design what the intervention is, depending on what we need to do for different people. Yeah, because a lot of it was tricky, like I remember some of them people were talking very descriptively about, they can't get to places because the gym they need to be able to get transport to get to where they want to go, but it's too expensive, or it's not, they can't get on the bus and get off it, or when it's too tiring to use it. So then when they get there, they're either pain or fatigue is worse and they can't do activity. So there's a lot of identifying problems, but not solutions just yet.
Yeah, okay. And then just one more point, Greg, it's really interesting. And I think Zoe mentioned this about fear, what we see, because I think especially around the physical activity, that's what we see in a lot of pain research, don't we? People do well for like 6 months and they seem to just tail off for whatever reason. And whether there's that link in with fear and stuff like that. I do wonder, and again, you might not have the answer to this, but those patients where they have immediate access to go back to see a healthcare professional when they do have a flare up 6 months down the line, whether that would then get them back on track to get exercising again. Because often I find with patients, they sort of hit the wall, they have a flare up and they just fall back into their old patterns, and then they're on a waiting list to see something for the next 12, 18 months. And there's whether that access of being able to get back in, because obviously it's a long-term condition, isn't it? Or whether it's 12 months down the line.
Yeah. Definitely there's some stories of a few patients I spoke to who had perhaps had more contact with a health professional after the program, whether that be, we don't have a system for this RNOH. There seems to be some people that had a few more physio sessions and a lot that don't, and I don't know why that is. But they weren't always health professionals from a program. They might just be, if they've got somebody who can reassure them, I think is just and reassure them quickly, I think is key. I know there's some people that had health professionals that could do that, or they had, I remember one particular story of someone who had a gym instructor who had particularly good knowledge or understanding of it and was for a family member. They've got somebody who can provide validated reassurance for them. That's certainly helpful.
Yeah, and because I worked in a community pain center about 5 or 6 years ago, and what we did like a small trial, but it ended up sort of tapering off a little bit. But they set like an exercise program that was set up by volunteers. So as soon as patients who completed the pain management program in the past, so they had that access straight away in the community, and that reassurance they actually got from each other. It was red tape and stuff like that. It all got closed down because it was run by volunteers. But sort of these networks for people seems to be, especially in those areas where there's these environmental influences, seem to be, for me, that seems to be an important thing moving forward here.
Yeah, and adding on that, I think a lot of the patients I spoke quite a lot about maintaining relationships with those they were on a program with.
Yeah.
And I'm saying some people weren't in contact with them at all anymore, but most of them were, and actually in the majority of the time it was a beneficial relationship, not always on directly related to physical activity, but it would be supportive in terms of, just advice and reassurance and encouragement and all those things. So another group of people that can be beneficial for them.
Yeah. Thank you for that, Greg.
That's all right.
Thanks. John?
Yeah, you just made me think there, Graham, as you were talking about if the next part of the next phase is about multi-centres, is about what different kind of programs offer in terms of, because obviously I can only speak for our program, but we have a friends and family session, a 3-month and a 6-month follow-up for our 15-day patients. So what difference might that make compared to a program that doesn't offer those things?
Yeah, and I think that's another reason for going for the different sites was because of those differences in what they offer already. So yeah, at Stanmore we offer, essentially it's a phone call at 3 months and 12 months after a program. And I know that patients told me quite openly in the interviews with Stanmore that a lot of the time doesn't really do much for them. So I think, it's about, I'm not sure what the answer is in terms of how we go about that, but I think if we have again, some flexibility in how we're able to offer support to people, I think is probably beneficial. I think the biggest thing when people spoke about if they had a couple of follow-ups was the timing of those follow-ups. So sometimes people get a follow-up maybe at 3 months and they tell me, well, I needed it at 6 weeks, or then they might have had a follow-up at 12 months, but they needed it 6 months earlier. So there's those type of, the timing I think is key, but again, that's difficult services to deliver, but that seems to be what the patients were feeding back.
I think it's like, but I was thinking though along the same lines as John was saying, because obviously a lot of this is thinking about what the intervention post PMP, but also when you look at some of those barriers, you would hoped they might have been addressed on a PMP. So would you be looking at what might be useful to include, like things like the friends and family session, or
Yeah,
I was thinking
and
particularly around, you know, like the symptom management and being able to adapt during a flare up. And
yeah, and I think PMPs do tend to address those things, don't they, for people? And
yeah,
I think that's the angle we're trying to come at. I think is that yeah, lots of those things are addressed, and but they still can resurface, or they can change, or new ones come up. So I think
but I guess there's how do you have more confidence in those things, isn't it?
yeah, yes, maybe that is I guess another step would be to look at how we can adapt PMP potentially
More
for those
stuff.
things. But that's yeah, which I guess yeah, like you said, trying to focus on what we're doing afterwards.
Yeah.
But then maybe there's something in there about how we finish off PMPs as well. But I always think there'll be a case of people that
Yeah.
need something more. But yeah, maybe there is something in there about how we do PMPs. But yeah, someone else's work, I think.
Okay.
Yeah.
Any other questions before we finish for today? Nope. Okay, thanks for joining us again, Greg.
Thanks for having me.
The screen, you know, when people flip round on the screen as somebody, I lost you then. Yeah, thanks for joining us again. Okay, and hopefully we can invite you back if Zoe presents her work, and likewise as you come to the end of your study. Okay,
Thanks.
thank you.
Thank you. See you later.
Bye bye. Have
Bye.
a good
Bye.
weekend. Bye bye.